They were concerned with MRSA, with clean medical equipment, in good working order, with staffing levels and good records. I have to ask, where are the compassionate role models? But it is wrong to blame all our failings on the managers, and there are some good managers, and most nurses and midwives, don't get me wrong, they are very compassionate and lovely people, very professional. But when you meet one, it's one too many, and we have to talk about these things. Now, so each one of us, whether we're a student, a practitioner, a manager, a teacher, has to take responsibility for trying to develop compassionate, trusting, culturally sensitive relationships with our patients. So how would this manifest with Mrs. Hassan? First, we need to show that we recognize the pain and anxiety and that we care. We don't need to speak the same language to show this. A little smile, maybe, acknowledging her presence, maybe a greeting in Turkish if we can manage that, will make her wanted and cared for. Regular use of an interpreter to explain to her every step in the way her care and encourage her to ask questions and responding to her requests, accepting the ways that she prays, eats, washes herself, without making her feel embarrassed and strange, are all appropriate actions. Above all, we need to recognize that she needs a family and that allowing her to see the family is very important. And we have to enable this without many restrictions in time or numbers, irrespective of existing rules. And this is why I was very pleased to hear that one of the students who won an award yesterday actually looked at the issue of visiting times. Involving the family in her care and decision-making is important. She will expect this. Finding a way to negotiate differences between her son's views and our views is another priority that must be handled sensitively. We must try to understand where the son is coming from and explain the reasons why we are saying or doing the things that we do. We have to remember that patients and families also have stereotypes about us, and they have heard from their family or their friends or the community negative stories about healthcare, and they are suspicious that negative things might happen to them too. So, with sensitivity and patience, most people find solutions and reach compromises. So to the last all-encompassing construct, that of cultural competence, which is, as I mentioned earlier, the synthesis and application of the previous three steps, if you like: constructs, awareness, knowledge, and sensitivity. Focus is given to practical skills because this is the application to practice. But most importantly, you will see there that we talk about recognizing and challenging racism and other forms of discrimination or oppressive practice. But as we noted earlier, the act of challenging requires courage. However, courage without wisdom is dangerous for both the person who is committing the otherwise courage act, and for the person that this act of courage is committed for. Gaining the wisdom to recognize unfairness and to challenge it effectively is a virtue. We must learn in similar ways as we've talked about in relation to compassion. Now, a good way that I like to use when assessing patients in culturally competent ways is to use this little model by Berlin and Fuchs, which is called LEARN. L stands for listen to Mrs. Hassan's problem. E for explaining your side of how you understand the problem. A for acknowledging the similarities and differences between the two. R making recommendations which involve Mrs. Hassan and her family, and then stands for negotiating the treatment plan, which of course has to involve and incorporate relevant aspects of Mrs. Hassan and her family's wishes. Now, I am nearly finished. The red light is on. Do forgive me for taking a few more minutes, but I just really wanted to conclude by saying that we are living in a multicultural world, and this is multicultural Holland, as you can see. I have listed there, I have taken this from the Wikipedia. Now, those of you who are very scientific, you're not supposed to be using Wikipedia, but it does have some good stuff too anyway, and I can't challenge these. These are 2011, I couldn't find any better figures, but this shows the major ethnic groups that you have, and of course there are a lot of others, but in much smaller numbers. Now, multicultural Holland is one of the leading countries, I have to tell you, as far as I know, leading the way in raising awareness and developing good practice in all the topics that I have spoken about. One of the theorists that I use and I admire is a Dutch person, is Gert Hofstede, and the other is somebody who lives not very far from here, I think, that is David Ingleby. As I mentioned earlier, I experienced this week a nursing symposium, a student nursing symposium and an expert meeting, and I was really very impressed by all the work that is being done in Holland today. And I know not only the ANC but many other schools and universities are doing the same. Also, I want to mention a friend that I met 10 years ago, that is Jan Bowie, who he's pioneered intercultural nursing for the elderly people. He has established a network. It's called the European Network of Interculturally Elderly Care, and it's worth visiting that website. I am currently working on a European-funded study called Jene, which is using the model that I have shared with you to develop materials for nursing, for nurses and other health professionals. And we're currently soon to begin a training program for teachers in our partner institutions, which is France, Belgium, Germany, and Romania, to enable teachers to provide culturally competent education. Ultimately, we wish to develop European standards for culturally competent care. But I have to add another little moan here, because I think we are lacking nursing leadership within the EU. And I know many projects have been funded, but none of them kind of reach the practice and in a systematic and kind of official guidelines way. And we need, I think, in my view, that needs to be improved. And this is the final slide. My messages for you are that we all need to develop the habit of cultural competence by using the findings of the various studies, by joining discussion groups. There are lots of discussion groups online that people who are interested in this area talk, raise questions and debate issues online. maybe joining societies if you're interested, such as the Transcultural Nursing Society or the European Transcultural Nursing Society, by talking to colleagues and by reflecting regularly on our practice. I think you get the message from me that cultural competence is not about knowing all the customs and practices of the numerous groups that may or may not use our services. It is about having a good deposit of culture-generic knowledge which will help us to approach our patients with sensitivity, knowing how to ask those right questions that will prevent us from having to say sorry too many times because we have offended yet another patient. And I say to all of you, don't be afraid to challenge cultural values, customs, practices which oppress and harm people and things that you are not comfortable with. Cultural competence should not be a rigid framework that imprisons our minds and limits our actions. But remember, this requires courage, which is based on wisdom, which comes from experience. Aristotle said that the brave person is not fearless, but one who can balance risk wisely. Conference, I urge all those of you who have many years of experience to encourage and nurture those who are new to nursing profession to develop the habit of courage, compassion, and cultural competence. Thank you.